Honorable Chief Guest, National Professor Brigadier Retired Abdul Malik, Guest of Honor, Professor Mir Jamal Uddin, Special Guest, Dr. Madhav Swaminathan, President, American Society of Echocardiography, Professor S.K. Parashar, and other foreign delegates, dignitaries, and participants, speakers. Professor Shaheedul Banerjee, convener of BD Eco 20, and his team members and participants. Ladies and gentlemen, very good morning, all of you. Today, I remember with deepest condolence for our colleagues from both home and abroad who lost their lives fighting in the front line in this pandemic situation. May Allah subhanahu wa ta'ala rest them in peace. Actually, in Bangladesh, general ultrasonography was actually started by the nuclear medicine department in those Institute of Postgraduate Medicine and Research, and in those days, mostly there was a small scale, and they use actually EMI scan machine, and mainly they were doing abdominal ultrasound. In 1978, National Institute of Cardiovascular Project was started by our chief guest of today's conference, Brigadier Abdul Malik. We consider him as a father of cardiology in Bangladesh. This institute started a technical cooperation with the National Cardiovascular Center, Osaka, Japan in 1980, with a view to develop the modern cardiovascular center in this country. As part of the manpower development for this institute, under this project, Professor Abu Jafar and subsequently me and few others cardiologists were trained in echocardiography and invasive cardiology in the National Cardiovascular Center, Osaka, Japan. Since the start of 1981, a full-fledged echo lab started working in National Institute of Cardiovascular Disease. Now, a lot of centers, including National Heart Foundation Center and Research Institute, BSMMU, Bangladesh Bangabandhu Sheikh Medical University in Dhaka, and many other centers are having modern echo lab. On October 15th, some of the cardiologists who were performing echocardiography in 2001 formed Bangladesh Society of Echocardiography to promote the excellence of the echocardiography in clinical practice. Since then, we are organizing CME program, workshops, and sometimes international meeting, though occasionally we have got an irregular performance. In May 2018, Bangladesh Society of Echocardiography formed Bangla Echo Consortium, Beacon, with the West Bengal Academy of Echocardiography to foster the mutual cooperation in this sophisticated field of medical science. In a similar manner, we are eager to develop an academic forum for cooperation with the American Society of Echocardiography. In this regard, I like to get support and pretty help of Dr. Madhav Swaminathan, President of the American Society of Echocardiography. Ladies and gentlemen, I like to congratulate you all for your participation. I also thank Professor Shaheedul Banerjee and his esteemed team for organizing such a conference. Beximo Pharma deserve a special thanks for their technical support. Wishing everybody a good day. Allah Hafiz.
Thank you, Professor Nazrul Islam, sir, for your brilliant speech and give your overview in the evolution of echocardiography in Bangladesh. Actually, now echocardiography is taking shape. Now we are in adulthood position in echocardiography, and Bangladesh Society of Echocardiography hope we will develop a skilled manpower with the collaboration of American Society of Echocardiography. So we look for the future opportunities with our development partners like ASE among Indian Society of Echocardiography. Now I'm requesting Professor Shaheedul Banerjee, sir, he is the convener of this BD Echo 2020, to give his welcome address. He is the convener of BD Eco 2020, and he is the Dean of Faculty of Medicine, Bangabandhu Sheikh Mujib University. And currently, he is the President of Bangladesh Heart Failure Association. He is also working as a Vice President of Bangladesh Cardiac Society. I am requesting Professor Shadul Krishna Banerjee, sir, to give his welcome address. Professor Shadul Krishna Banerjee, sir, please unmute yourself, sir. Kamrul, yes.
Sorry for the electricity disruption. Very good morning to everybody. Honorable President of the Bangladesh Cardiac Society and the General Secretary of Bangladesh Society of Echocardiography, President of the Bangladesh Society of Echocardiography, our Chief Guest, National Professor Brigadier A. Malik, and the special guest, Professor Dr. Madhav Swaminathan, the President of the American Society of Echocardiography, and the other dignitaries, and all panelists, all moderators, all participants. Warm greetings and best wishes to all national and international faculties, chairpersons, panelists, and participants of BD Eco 2020. BD Eco is the annual academic conference organized by Bangladesh Society of Echocardiography every year, and I believe all of you are well acquainted with the reason of the arranging a virtual summit for this year, that is the COVID-19 pandemic. Continued medical education, live case presentation, and hands-on training are regular academic activities of Bangladesh Society of Echocardiography. I want to express my deep respect and greetings on behalf of Bangladesh Society of Echocardiography to the chief guest of the inaugural session, National Professor Brigadier A. Malik, who is the father of cardiology of Bangladesh, the founder director of National Institute of Cardiovascular Disease. He was advisor of the first interim government of Bangladesh, as well as president of Bangladesh Heart Foundation. Bangladesh Society of Echocardiography will remain ever grateful and thankful to the legendary figure in the world of echocardiography, Professor Dr. Madhav Swaminathan, the President of American Society of Echocardiography, for his kind consent to remain as a special guest as well as speaker in the sunrise session of this international summit. We are also grateful and we express deep respect to all international faculties for their commitment and who have taken a lot of troubles to manage their time and prepare the speech for our conference. Thank you all. I hope the academic conference involving the legendary figures in the field of echocardiography of the world will bring us close together and will act as a breeze of mutual friendship. This will open the avenue for exchange of skills and knowledges related to echocardiography in this annual summit, and will give us the opportunity to exchange skills and knowledges. I also believe that this summit will be very helpful and will give us the opportunity of sharing and learning basic and advanced knowledges in the field of echocardiography. Expecting a successful day-long conference, I wish you all the best. Thanks to honorable faculties, panelists, moderators, and participants again. Stay safe with a good health. God bless you. Thank you all.
Thank you, Shaheedul Krishna Banerjee, sir, for your welcome space. We are really blessed as like your bright space. And now I'm requesting our guest of honor, Professor Mir Jamaluddin, sir. He is the Director of National Institute of Cardiovascular Disease, and he is the Secretary General of Bangladesh Society of Cardiovascular Intervention. He is also Course Director of Bangladesh Shaheedul International Course, and he is also served as a Vice President in Bangladesh Cardiac Society. We are respecting his valuable space as a guest of honor. Professor Mir Jamaluddin, sir, would you please give a talk?
Am I audible?
Yes, sir.
Audible to you?
Yes, sir.
Good morning and Assalamu alaikum. It's my pleasure to tell something in this occasion, this BD intervention virtual summit, and I must have to respect our chief guest, Professor Brigadier Malik, who is the father of cardiology in Bangladesh, and the president of the Society of Bangladesh Society of Echocardiography, Professor M. Nazrul Islam, Secretary General of Bangladesh Society of Echocardiography, Professor M. Fazlur Rahman, and convener of this program with the intervention, Professor Shaheedul Krishna Banerjee, and our special guest, Professor A. Madhav. All the participants as well as speakers from home and abroad, once again, with respect, I am giving my address. Echocardiography, Bangladesh Society of Echocardiography is the icon of echocardiography in Bangladesh. And I think the person who has started this Society of Echocardiography, Professor M. Nazrul Islam, he is the pioneer of echocardiography in Bangladesh. And my respect to all the participants, as because in this early morning, some are in the night, approximately at night, and at 10 p.m. And we are also some in the early morning who are taking the part in this conference, in this virtual summit. So I must have to respect all. And we know that echocardiography is one of the part and parcel of cardiology. Whether you go to the interventional cardiology, you go to the electrophysiology in cardiology, all requires echocardiography. And this is, I think, that this is the very important part of cardiology. And from the different authors, different speakers from abroad, mostly from abroad as well as from home, they will give us idea regarding the latest update of echocardiography in worldwide. In this COVID era, how to overcome and how to do the echocardiography, which one is essential, which one is not essential, everything we shall have to learn from morning to the entire day, and we are preparing ourselves for learning today, and it will remain ever for our whole life that we have learned this echocardiography in this COVID era by the renowned echocardiographist from all over the world. And with these few words, I must have to thank all the participants as well as speakers and the persons who has arranged, particularly Professor Shaheedul Krishna Banerjee, who have given us much time for this arranging this program. Besides this, our Secretary General, who is a bit ill now, even then he has participated and arranged after sitting in his bed. So we shall have to congratulate him with this health condition. He has also availed the program and maintained the program, and he is the key, one of the key person of this intervention, BD Echo Summit. With these few words, I must have to conclude this my speech, that we are learning from Echocardiography Seminar Summit, and we shall be able to be an international level echocardiography in Bangladesh. Thank you all.
Thank you, Professor Mir Jamaluddin, sir, for your valuable space. Now we are actually waiting for highly expecting space from our special guest, Dr. Madhav Swaminathan, who is the professor of anesthesiology at Duke University. Currently, he is serving as the president of American Society of Echocardiography. His name is enough to introduce himself. As you know, he has already a lot of awards, honors, and recognition. Among them, he already received 16th annual Feigenbaum Lecture Award 2015, MLK Community Service Award 2013, and Strength, Hope, and Caring Award 2011. And we really believe he will give his speech with the future direction to develop future opportunity in between Bangladesh Society of Echocardiography and American Society of Echocardiography. Now I'm requesting Dr. Madhav Swaminathan, please give your speech for our wonderful audience.
Thank you so much, Professor Azam. This is indeed an incredible honor to be here. Assalamu alaikum, good morning, good evening, good afternoon, and very early good morning to some people who are on this, who are watching right now, wherever you are in the world. This is indeed incredible, and thank you so much for the honor, love, and affection that you have shown. I would like to say at the outset that a couple of months ago, I did transition my presidency, and I stepped down, and Dr. Judy Hung is the current president of the ASC, and I'm happy to report that there was a peaceful transition of power at that time, and it really went well. But during my presidency at ASC, one of the things that I really wanted to focus on was expanding the tent, understanding and realizing that echocardiography is actually a wonderful tool. It is a technology that has allowed us to take care of patients with cardiovascular disease around the world. It is incredibly useful, it is incredibly valuable, and it is incredibly easy to do. There are so many technical advances that have taken place around the world over a period of time, but the number of sheer people that we've helped with cardiovascular disease has been absolutely incredible. Not only that, echocardiography is used everywhere from radiology to cardiology to critical care to emergency department to anesthesiology, you name it. The cardiovascular ultrasound is so popular in its use, and that's because you all have made it easy to do. You all have given us an opportunity to use echocardiography to take care of any patient with cardiovascular disease, and that is incredible. And for that, I salute everyone who takes an echo probe in their hand and does magic with it. One of the things that I wanted to do during my presidency was expand that exact tent and get more and more people under the echo umbrella. It doesn't matter what specialty you practice in, but the very fact that you use echocardiography makes you a very valuable member of the echocardiography community, and you should be welcome everywhere that you serve. And that leads me to my second point, which was diversity. One of the reasons why one of the things I realized when I became the president of the American Society of Echocardiography was that it was, I may be the only anesthesiologist in this domain right now. But what that told me was that the ASC was one society that welcomed every user of echocardiography, anesthesiologists, cardiologists, critical care, whoever it may be, it doesn't matter. If you love echo, you're welcome. And I think that should be how we should welcome everyone who uses echo with open arms. It does not mean if you're a doctor or if you're a sonographer or whatever it is. If you love echo and you do echo and you can take care of patients with cardiovascular disease, you are welcome. So diversity to me took on a new meaning when I became the president of the ASC. The other thing was, expanding international collaborations. And one of the things that we see here is that, we've got 32 international alliance partner members of the ASC, including the Indian Academy of Echocardiography, including the Indian Society of Cardiovascular Anesthesiologists as well. And I'm looking forward to a collaboration, and I will help as much as I can to ensure that the Bangladesh Society of Echo, which is full of such wonderful people here, such pioneers of echocardiography in a region like Bangladesh, it is incredible. And I would urge the society leaders to work with the ASE to become international alliance partners. There is no cost to this. There's only a benefit. And the benefit is that we keep an open channel to talk. And when we keep an open channel to talk, good things can happen because we talk to each other, we collaborate with each other, we work on projects together, we work on guidelines together. You share your experiences with us and you enrich us with your knowledge. We do the same with you. And so with an exchange of experiences, it becomes mutually beneficial. Remember, there are no experts here. We are all facilitators. Some of us have experience in some things, others have experience in other things. So we're all sharing our experiences, and that's how we learn from each other. And that's what I see here in the Bangladesh Society of Echo annual meeting. It is so wonderful that you all have pivoted to a virtual meeting in this time of COVID. I'm grateful to all the people who are fighting in the front lines, taking care of patients, especially those with cardiovascular disease, especially those who have lost their lives in doing so, and the people who have fallen. With that, I will say that, congratulations on hosting a virtual meeting. I'm absolutely honored to be mentioned in the same breath as all the wonderful people here, and I'm looking forward to learning from all of you. Thank you so much for the kind invitation.
Thank you, Dr. Madhav, for your wonderful speech. Actually, as you know, before that, I want to tell something regarding around 500 participants already registered in our program, and we hope it will more than that. And as you rightly mentioned, echocardiography is a wonderful tool. Actually, as a clinical cardiologist, we very much used to use in our daily practice is stethoscope and echocardiography. As you know, stethoscope we use to see the chest to create a mental image what happening in the heart. And similarly, echocardiography we use as a bedside test. It is more than a stethoscope. So we believe in tomorrow, in future, it will be a very essential tool as like a stethoscope. Thank you very much, Dr. Madhav, and we hope for the future opportunities. Now I'm requesting our chief guest, Professor Brigadier Azam Malik, give his special talk, and after that, I believe he will inaugurate our session. After that, we can peacefully transition to our scientific session. I just give a few words regarding our National Professor Brigadier Azam Malik. He is the founder of cardiovascular disease study group. Like he started initially in IPGM, then he can start National Institute of Cardiovascular Disease in Bangladesh, 1978. Then he found National Heart Foundation. And most of all, he is the founder president of SARC Cardiac Society, and he is the founder president of Bangladesh Cardiac Society. And he already served as the country as an advisor in interim government, and he is our inspiration. So now I'm requesting our National Professor Brigadier Azam Malik to give his speech. After his speech, we will be happy to inaugurate our scientific session. Sir, Professor Brigadier Azam Malik, sir. Sir, can you hear me, sir? Amrul?
Sir, sir, unmute yourself, sir.
শোনা যাচ্ছে? এখন শোনা যাচ্ছে?
শোনা যাচ্ছে, স্যার।
শোনা যাচ্ছে।
Yes, sir.
Thank you very much for inviting me. Now, I am really happy today. Respected President of the organization, President, and ইকো হচ্ছে কেন? ইকো হচ্ছে কেন? Respected.
সবাইকে মিউট করেন। সবাইকে মিউট করে দেন।
মসফি
স্যারের এখানে দুইটা ডিভাইস অন করা আছে। স্যার আনমিউট yourself, স্যার।
Moderator, please mute all everybody else.
Sir is still muted.
কাবুল তুমি স্যারকে আনমিউট করো।
স্যারকে আনমিউট এবং আর সবাইকে মিউট করে দেন।
স্যারকে আনমিউট করেন কামরুল।
স্যারকে আনমিউট করো।
স্যার
Bismillahir Rahmanir Rahim. Respected chairman of the session, special guest from home and abroad, distinguished participant, faculties, I am very happy to be invited in this important inaugural session. Today, we are in the midst of COVID-19. Physical meeting is not possible, but because of this scientific advancement and technology, we can now participate in virtual meeting. Now, first of all, I thank all of you for organizing this very important session. Professor Nazrul Islam has nicely and in a brief way has told about the history of echocardiography in Bangladesh. I would like to say to you that in 1960s, when you used to be getting training in UK, at that time echocardiography was not at all in the field. At that time it was phonocardiography and other things. Echocardiography gradually came, and this echocardiography is today is very important tools in the field of cardiovascular field and playing very important role. And I am sure it will take the lead, and this is non-interventional, not harmful, and you can do a lot of good to people without doing any harm. But what is there? It is not the machine. It is the man who is behind the machine. It is very important. That is the interpretation. So here, importance is echocardiography, the machine will be there, the man behind the machine got to make it, and it does not, overnight one cannot be a good echocardiographist. So I am very thankful and I am very delighted to see that Bangladesh from out of nothing has come today in a very good shape, and in the international field they are moving in various interventional and non-interventional fields. So if you want to keep it up, you will have to work hard. And theoretical knowledge is important, but practical knowledge is very important. So I must urge all these young people that you should try to learn, be sincere, devoted, and don't run after money. So if you want to work sincerely, definitely you will achieve the success. Success does not come overnight. And here, our profession, health profession, is a noble profession. We say service to humanity, service to God. So here we should try to do good to the people, and cardiovascular field cardiology, cardiovascular diseases are going to be the number one today, and it will remain as such. So we will have to be the treatment, and for treatment we need investigation, and this is very good investigation, and I am sure all of you will get chance today to learn from each other, and you will learn from this foreign and countries faculty. So please try to learn and utilize it properly. So thank you very much for inviting me, and I am sure Bangladesh will proceed, go ahead, and our people are always bright and intelligent, so we should guide them. And I must thank all the leaders, Shodol Banerjee, Professor Nazrul Islam, and Fazlur, Rahman, and all others who are there. I cannot name all of them, but all of you are working very hard. Thank you very much, taking the lead and try to serve the people. Our life is very short. We come to this earth by birth and leave it empty-handed. So whatever time we pass, we should try honorably, with dignity, and trying to do good to people. And you are doing good, and try to learn and give service to people. So thank you very much for inviting me. I am sure Bangladesh Society of Echocardiography, with the assistance and cooperation from other societies, will go ahead. World has become now a global village. Whatever happens here, it affects others. So whatever you are doing here, other people will observe you. So try to be sincere. One of my advice will be, if you are not sure about something, try to get cooperation or help from others. Don't hesitate, because nobody knows everybody. Everybody does not know everything. So you may know something which other people do not know. So try to learn from others and be helpful, cooperative, and try to good to the people. Thank you very much for inviting me. I am very happy that Bangladesh Society of Echocardiography and other interventional and all the societies, all of you are working very hard. When our country was independent in 1971, there was nothing here. So you have taken the lead, and I am very happy. Thank you very much. God bless you. And I always pray for you that you should go ahead. Thank you very much for inviting me. Thank you. Thank you.
Thank you, Professor Brigadier M. Malik, sir. After his wonderful inauguration, now we can move on our scientific session. Our first scientific session, named Padma Sunrise Series. Now I'm requesting Dr. Professor Sabina Hashem and Dr. Nilufar. Please take the charge to continue with our scientific session. And we must give special thanks to our Professor Brigadier M. Malik, sir, National Professor. He gave us a significant thought to keep continuous learning. Don't hesitate to ask our any colleague for learning. Learning is universal. Thank you very much, sir, for with us. Now we are move on our next session, sunrise session. Now Professor Sabina Hashem and Dr. Nilufar will take the charge to continue the session. Professor Sabina Hashem and Dr. Nilufar. Can you hear me?
Yes, sir.
Okay. You can start your sunrise session.
Am I audible?
Yes. Yes.
So, a warm welcome to the Padma Sunrise session of 2020. This is our first virtual conference of ECHO from Bangladesh Society of Echocardiography. Professor Dr. Sabina Hashem moderating this session, and my co-moderator is Dr. Nilufar Fatima. So, Nilufar.
Welcome participants from home and abroad to this virtual conference of Bangladesh Society of Echocardiography, BD ECHO 2020. I am Dr. Nilufar, and now currently positioned as Secretary International Affairs. I am very grateful to all of the international faculties who have who will be participating this meeting. And give their valuable time and knowledge to us. And this conference is first time as a virtual one because of COVID pandemic. So today we have renowned cardiologists and faculties and also anesthesiologists from all over the world, and chairpersons for this session is Professor S.K. Parashar sir, Professor Shahbaz A. Qureshi, and Professor Madhav Swaminathan, Professor A.K.M. Fazlur Rahman, and Professor Mir Jamaluddin sir, Dr. Aasha Gopal, and Professor M. Mahboob Ali, Professor Khondker Shaheed Hussain, Professor M.T. Azam, and Brigadier General A.F.M. Shamsul Haque. And the panelists are Professor Ranjit Chandra Khan and Professor M. Touhidul Haque, Professor Mahbubur Rahman Babu, Professor A Muqueet, Dr. Ganapati Aditya, Dr. Nupur Kar, Dr. S.M. Shaheedul Islam, Dr. Aasha Gopal, and Dr. Haripada Sarker. I would like to request the chairperson to chair the session. Sabinapa.
Now, may I request our first speaker, Dr. Madhav Swaminathan. He is a former president of American Society of Echocardiography. He's a vice chair of faculty development in Duke anesthesiology and a professor of anesthesiology, Duke University School of Medicine. Sir, please, can you share?
Thank you so much. Thank you so much for the kind invitation. I'll go ahead and share my screen right now. And hopefully you can see my presentation.
Yes, yes, sir.
Okay. Thank you so much. Thank you again. Wonderful session that you have and wonderful meeting. And I enjoyed listening to all the stalwarts of echocardiography in Bangladesh. This is truly inspiring to see the work and effort that is being done in Bangladesh. So thank you so much for the kind invitation. So my job is to talk to you about the role of echocardiography in the ICU in the COVID era. I have no relevant disclosures. And first of all, I'd like to say, to recognize the people who have fallen to COVID-19 and salute the heroes who are working in the front lines every day. So my thanks to all of those who are working in the front lines all over the world, especially those who are taking care of COVID and those who are using echocardiography and whatever they can to help people. So the learning objectives for this particular talk are to review the impact of COVID-19 on critical care services, describe the value of echo in critical care, and to discuss the risk mitigation strategies. So as an outline, I'll talk about the impact of COVID, what it has had on ICU care, what the cardiovascular burden is, the value of echo in the different stages of COVID-19, the different strategies we can use, including prevention and point-of-care ultrasound and artificial intelligence, followed by a summary at the end. So let's start by discussing what the impact of COVID has been. And it is no surprise that if you look at the timeline from the beginning, this is now old news, how much the death toll is climbing. Just in the very, very few months, we have seen the world impacted by this tremendously ever since December of last year, when the first patient developed symptoms of the coronavirus in Wuhan, to the identification of the virus of COVID-19 on January 7th, up to the first case outside of China on January 13th. And then you can see how rapidly things have escalated all around the globe. And every day, every number becomes an outdated statistic, which is really sad, including this one, where I took this one last month, and it just doesn't make sense anymore because the numbers have skyrocketed even beyond that. The scale of this pandemic is something that none of us have ever seen in our lifetimes and are unlikely to see for generations to come. Hopefully, this is just a once in a generation or once in a century kind of event, and hopefully it never happens again. But if you look at the cumulative new cases around the globe, it is just this graph just gives you a different story completely. And just today, which is actually November 13th in Bangladesh, but it's still November 12th here in the United States, this is the COVID-19 dashboard at Johns Hopkins University, where you have 52 million cases globally with 1.29 million deaths. This is 1.291837 deaths too many. And it shouldn't be that way, with 242 deaths just in the United States alone. But then again, Bangladesh isn't spared either, with 427,198 deaths so far. Cases so far, and 6,140 deaths. This is no small matter for any country in the world to bear, this sort of pandemic and the devastation it has caused. So needless to say that we all have a role to play. We all have a very important role to play. And as was mentioned just before me, this is a global community. What happens in one place does not stay in one place. It travels around the world. We are all interconnected as a community, and we all should learn from each other. So let's think about the impact of COVID on two things. One is the provision of critical care services, and the other is the cardiovascular burden that is imposed by this virus. So first, when we think about the provision of critical care services, the impact is that you have fewer non-COVID beds available. So the regular care is also impacted. You also have to create separate units. This is a drain on the infrastructure. There's a strain on personal protective equipment that you have to have for carrying all of these cases and all the suspected COVID cases as well. And as cases rise, the strain on PPE supplies becomes a problem. Now, none of us had used the word or the letters PPE before this very much, but now it's become like everyday use. This strain on staff, now that's the mental health strain. We all are going to suffer from the consequences of not being able to do what we do to relieve our stress while taking care of COVID-19 patients in the ICU or in the clinic or anywhere else. And this put a strain not only on our mental health, on our physical health, but on our financial health as well throughout the countries. And a lot of us cannot afford to do that anymore. What about the disease burden? I'll talk briefly about the cardiovascular effects, but then of course there are cerebral effects. This is a systemic disease. There are pulmonary effects. There's acute kidney injury. There are microvascular thrombosis. There's hypercoagulability and disseminated intravascular coagulation. And there's vomiting and diarrhea. So you can see the systemic impact that COVID has throughout the body, not just the heart. And then when you think about the cardiovascular burden, that is somewhere where we all come in as cardiovascular specialists, armed with the tools that we have to help people with cardiovascular disease. Now, when we think about the cardiovascular burden, there are factors which decrease the oxygen supply to the body, which include pneumonia, ARDS, hypotension, and bradycardia, and all of these initiated by the cytokine storm will serve to decrease the oxygen supply. And then you have inflammation, including that cytokine storm and release of pro-inflammatory mediators. And then you have microvascular complications such as thrombosis and endothelial dysfunction. And all of these serve to increase or enhance that cardiovascular burden that we all see in COVID-19 cases. If you haven't seen it already, you're likely to do so very soon. So what about echocardiography in COVID? And you'll hear about this in the course of the day and the sessions to come. But in the ICU, you will see frequently a lot of cardiovascular manifestations of COVID. Even if you're not a primary critical care person, you will be called to look after patients with cardiovascular disease, and that may include right ventricular dysfunction, myocardial injury or heart failure with reduced ejection fraction, cardiogenic shock, which is where critical care folks will come in to take care of these patients. Cardiac tamponade is also an infrequent complication. Pericardial effusion is seen very often. Stress cardiomyopathy, STEMIs, or even heart failure with preserved ejection fraction. These are all the spectrum of cardiovascular diseases or manifestations of COVID-19 that you can see, where echocardiography becomes crucial in handling the diagnosis and is very suitably equipped to give information in real time very quickly to clinicians taking care of these patients. So it is an invaluable tool to look after patients with COVID-19 in the unit and beyond. So whether it's early in the disease with impending shock or just to establish a baseline for patients, or during the COVID crisis, when you have shock, you can have tamponade, you can have valvular involvement or ongoing myocardial injury, to even after patients leave the ICU with sequelae of myocarditis, chronic disease, decrease in function, valvular deterioration, or even look at function after intervention. In all these three areas, echo becomes a critical tool to evaluate and take care of patients with cardiovascular disease in the COVID pandemic, not only before, but during and even after. So that includes the critical care services. So what should be our strategy in echo services? All of us know how to do echocardiography, but how do we manipulate or adjust our echocardiography services to match the burden of the pandemic? Now, very early on in the pandemic, I had organized a group at the American Society of Echo to release a statement. These were a group of experts that had coalesced. I'm by no means an expert. I just have some experience, and I was sharing my experience. But I pulled together this group of very fine people, and we constructed that statement. Now, remember, this was in record time. We did this within 5 days. We released a statement for guiding echo services throughout the world. And the reason why we did that was because people didn't know what to do. This was March 18th. This was very early on in the pandemic, and people didn't know what to do. I was getting emails and messages throughout very quickly saying, what do we do? How do we organize our echo services? We don't know what to do. And so this is what we did. We got together a group of people and released a statement, and we focused on who we need to do an echo on, where we need to do the echo, and how we need to do the echocardiograms. So in terms of who we need to do the echo on, and we need to use appropriate use criteria, this is very useful. We should do it only when there's a clinical benefit that is likely, when there's a management decision that may be pending, such as use of inotropes or mechanical circulatory assist devices. We made special provisions for TEE, stress echocardiography, pediatric echo, and intraoperative echo. All these required special statements that were released by subspecialty members. The important thing was to triage people who come with cardiovascular disease and test positive for COVID-19. The other question was, where do we do this? And so the goals of this are to have minimal impact on non-COVID cases, because we still have a service to run with non-COVID patients. We need to protect our echocardiographers first and foremost, in addition to protecting our patients. We need to make sure that the equipment is reusable. And when we think about equipment, some of the considerations are whether to have a dedicated room versus portable equipment, whether to have dedicated equipment itself. And what about the PPE usage, and how do we ration that in a situation where we have a resource constraint and we don't have enough PPE supplies, and how do we monitor that? Then the next thing was how to do it and what our approach should be in terms of what to do with an echocardiogram and what to do when patients come in for echocardiography, how do we do it? And so the way we did that was to create this algorithm, which we released, and you can still find it on the ASE website, and it stratifies people according to the COVID status and tells you exactly how to go about doing echocardiograms with airborne precautions or droplet isolations or contact precautions, and what special precautions you might need to have. The other thing was that we talked about the POCUS protocol, or the point-of-care ultrasound, and what value point-of-care ultrasound has within the COVID pandemic, how to do an abbreviated exam, how to focus on exactly the findings that you want, and how to get exactly the information that you are looking for in patients with myocardial manifestations of COVID-19. And so this outlines really well what we need to focus on. And there's an algorithm that we developed regarding COVID-19, which is suspected, how to do the initial evaluation, how to do the point-of-care ultrasound, whether it is sufficient or not sufficient, and what to do after that. Now, this is an example of the use of artificial intelligence or in point-of-care ultrasound, where you have devices such as this, and I use this with permission, where it guides even the novice practitioner. So even if you have people or critical care intensivists or nurse practitioners or even paramedics who want to use this device, it will help these practitioners find the right views, even if they haven't done an echo ever before. And it will guide them to the views, and will provide them with information regarding ejection fraction, regarding progress of information, and it will even tell your service, your echo lab, as to who has done what and how well they've done it. So it's a great tool that's emerging using artificial intelligence for echocardiography images. This is another example of a software as a service model from a UK company called Ultramics. Again, I don't have anything to do with them, but I was really impressed by what they have. And they can use any image acquired from any vendor, whether it's Philips or GE or Siemens or whatever it is, and they feed it into the system, which gives you automated EF and automated parameters that are really, really helpful for even the novice practitioner, and even to track long-term usage. And it synchronizes perfectly with whatever systems that you might have. So there is a definite role for artificial intelligence in the care in echocardiography as you use it to care for patients with cardiovascular disease. A brief word about intraoperative echo as well. When we try to talk about this in critically ill patients, we focus on what is the aerosolization risk and what is the contamination risk. And when we think about the aerosolization risk, we think about non-intubated versus intubated patients. And in non-intubated patients, there's a high risk of cough. There's no option for source control. And the operator is by definition in close proximity. You're very close to the patient. There's no chance of social distancing. In intubated patients, they are mechanically ventilated. There's risk of aerosolization with endotracheal tube intubation and extubation and airway manipulation. And again, the operator is in close proximity. But then what is the contamination risk? There are increased secretion risks from upper airway and the oropharynx, and the frequent contact with contaminated secretions, these have multiplicative effects on other surfaces as well. So there's lots of contamination risk going around. Now, a brief word about a clean room and a less clean room. Now, whenever you have two rooms that are separated by airflow, so there's a high area of high pressure which flows to an area of low pressure. And the operating room that we have designed are designed to be positive pressure rooms which feed into or blow air into an induction room or a hallway, which is the less clean room. So it keeps the operating room clean. On the other hand, an airborne isolation room in the ICU is a negative pressure room where you have a hallway which has clean air coming into the less clean area. The entire idea in both these situations is to avoid contamination of a clean area. The special problem becomes when you have a contaminated patient in a clean area, such as the operating room, and there you have to take very, very special precautions. So what are the principles that we follow? We need to assess the indication for TEE, defer or cancel TEE if it's unlikely to change management, and consider alternatives or less risky imaging modalities if available. So first, we think, is there in an emergent cardiovascular surgery case is posted, is a perioperative TEE essential or indicated? If it's yes, we proceed with it with adequate PPE precautions. If it's not indicated, we consider repeat TTE before the start of the procedure to confirm LV and RV function. And then if there's unexplained hemodynamic instability, we proceed with the TEE in the operating room. So what do we consider essential? So some of the essential indications are myocardial infarction with mechanical complications such as papillary muscle rupture, type A aortic dissection, infective endocarditis with valvular involvement, initiation of mechanical circulatory support, prosthetic valve assessment, and hemodynamic instability with suspected complications. What about living with COVID-19? And this is not going away anytime soon, so our critical care services are going to be bent, and a lot of strain will be put on them when we live with COVID-19 throughout the world. And this is not going to go away. So the idea is to have a four-pronged strategy where we screen for all patients for COVID, we defer the COVID positive cases, we build capacity, and we plan for a long duration of this problem. We also need to sanitize facilities and sanitize equipment and ensure that PPE is available for all practitioners and ensure social distancing wherever we practice this. And this may become the new norm for a long, long time to come. I'm hoping it isn't, but I'm guessing that it will. We also have a plan for inpatients. We have to have portable equipment, especially for critical care units. Dedicated COVID areas have to be thought of. We need primarily to protect not only our patients, but also our staff who are taking care of them. These are frontline workers, and they need to be protected. We also need to follow guidelines such as local trends and local health authorities when they tell you what's going on. And we may need to flex up or down on our services. We may need to relax our restrictions when the phase of the pandemic is lower, and we need to flex up and increase our services when the pandemic phase is fully raging on. So these are some of the four-pronged strategies and principles that we may have to follow living with COVID for the conceivable future for now. Whatever kind of service that we have in terms of echocardiography, wherever we are in the world, we will need a long-term strategy for this, and a short-term strategy is not going to work. So I'd like to end with some key points. I want to end on time. So in summary, echo is an essential imaging modality in critical care COVID cases, as we just talked about. Innovative technology is essential, and it may become very useful to protect from COVID while preserving the quality of echocardiography, and artificial intelligence might come in very handy. And remember, these devices come at a fraction of the cost of some of the bigger echo machines that you have, and they preserve portability as well. And again, we may need to follow strict standard sanitation protocols to protect patients and staff. That is absolutely essential, and that may happen for a long time because we need to develop plans finally to live with COVID. I want to thank you all for your kind attention. Thank you for the invitation to speak at the Bangladesh Society of Echo virtual meeting, and I'm really happy to be here. Thank you for your attention.
Thank you, Dr. Madhav Swaminathan, for your brilliant, informative speech and guidance for performing echo in COVID pandemic. For dear audience and participants, you can ask question in chat box. We'll discuss after another lecture. So our next speaker is Dr. Colonel S.K. Parashar sir. Though he is in his vacation in USA, still he agreed to be part in our virtual meeting. He is the founder of Indian Academy of Echocardiography and past president of Indian Academy of Echocardiography and Indian Cardiological Society, and and senior consultant and director of non-invasive cardiac lab, Metro Heart Institute. And his topic is echocardiographic assessment of RA and RV. Welcome, Dr. Parashar sir. Please share his screen.
Well, thank you. It is going to be more of a revision lecture for the youngsters because majority of you are already doing what I'm going to tell, and you must have heard some lectures pertain to this topic, so it may be more of a revision lecture. So as we know that right atrium is the gateway to the right heart. The right heart lesions are usually characterized by a pulmonary artery hypertension and increased pulmonary vascular resistance. These lead to an increased RV overload, and this ultimately leads to RV failure and a raised right ventricular end diastolic pressure. And because RA is intimately involved and bears this RV intestinal pressure, so this, because of this, it undergoes a right atrial remodeling, leaving an effect on the RA size and function. So that ultimately, most of the right-sided lesions have got an effect on the right atrium. So we'll discuss very briefly something about the functions of the right atrium and the right ventricle. Now, suffice to say that for any study or so, the dimensions are extremely important because they have got an effect on the overall prognosis of the disease also. So in a right atrium, remember, basically for the youngsters, a apical 4-chamber view, end systole, and then because at end systole, the RA is at the maximum dimension, and these are some of the dimensions. And we also calculate the area, which is about 18 centimeters square, but now in the era of a body surface area, it is less than 9 centimeters per body surface area. Then coming to the RA pressure, this is very well known to you that the RA pressure, the direct evidences are, we are talking of mainly non-invasive, is an IVC diameter, whether it is increased or normal, and IVC response to respiration, whether it is more or less than 50%, and like a left-sided lesion, a tricuspid E velocity divided by E prime ratio by more than 6 or so. And based on the IVC, the general consensus of the pressures are that when both are normal, then the mean right atrial pressure is near about 3. And when one is normal and one is abnormal, the mean pressure is about 8 with the range of 5 to 10. And when both are abnormal, then it is usually more than 15, to coming to near about 20. So that this is the general sort of a guideline for remembering the mean RA pressures when depending upon the size and collapse. And sometimes when you have got a significantly increased RA pressure, then the hepatic vein have to drain against an increased pressure. So there is a systolic velocity significantly decreased and there is a predominantly diastolic velocity. Now, as you know, we normally don't calculate the volumes or so because it is very challenging and with very limited data. But just for the completion's sake, if one can try, they can try to calculate a right atrial volume by a 3D methods or so. And these are some of the normal values. But as I mentioned earlier, that normally we are not doing or usually on a day-to-day basis, but one can attempt or do of this a 3D of the right atrial volumes or so. Then remember, when coming to the RA strain, the RA modulates RV filling by 3 mechanisms. One is the systolic mechanism, known as a reservoir function. then the early diastolic diastasis, and the late diastolic, that is a booster function. And most of the studies are usually done in the reservoir phase, because at this phase the RA is exactly at a maximum dimension. And when we do a strain of the RA, it is divided into three walls: the lateral wall, the roof, and the septal wall. And then you measure from the lateral annulus and measure the endocardium. And this is what you can get values. Again, the 6 segments are divided, and you get more the values which are depicted above the baseline, because it is a positive strain. And the normal values vary, but it should be more than 25%. But this is the range of the RA strain present in these cases. And these are some of the when there is a normal individual, you can see the RA strain is almost more than 25 or so. But the more the studies are done in those cases who have got a pulmonary hypertension, and here you see a case of a pulmonary hypertension in which there is a significant enlargement of the right atrium, and the strain is hardly about 8% or so. So most of the studies have usually been done on the cases of a pulmonary hypertension, and as a result of which the RA strain can give some indications as seen in this situation. But to be very frank, it is not done on a routine basis also because of a multiple limitations. So it is my personal view that it is more for research and conference purposes rather than any day-to-day functioning also, because of a lot of technical limitations. Now, so the summary of the RA function: whenever we give any function, we always give 2-dimensional spectral Doppler, tissue Doppler, and the hepatic vein. And the time does not permit me to go into detail, but see every aspect of modality of the echo to get the RA functions. Coming to the RV functions, why is it important to evaluate RV functions is that it has got a strong prognostic factor in a number of diseases, and the prognosis is strongly related to RV function in pulmonary hypertension, and RV failure due to increased afterload is the main cause of death. Similarly, whether it is a valve surgery, whether congenital heart disease, transplantation, assist devices, you see the operative mortality is much more in those patients who have got a RV dysfunction both during surgery and follow-up. And this also holds true for cardiac transplantation, in which the RV function is very important and can go up to about 20%, and anterior MI also. So that the importance of RV has come up because in a large number of diseases, it has got a prognostic significance. The problems in evaluating this are because of its location behind the sternum, peculiar shape, compromising the RV endocardium because of a large number of trabeculations. So because of this anatomical limitations, it may be they are the problems in evaluating the RV, and the inlet, outlet, and the apical portion cannot be seen in one scan plane. But the two main ones are this location behind the sternum and lot of papillary and lot of trabeculations. Now remember, the basic rule in an echocardiography is imaging every plane in which that particular structure is seen. So that is a multiplanar imaging is much better rather than focusing on a single plane. So that means the RV can be seen in an RV inflow view, parasternal long axis view, short axis, apical, subcostal also. But everybody should practice what is known as a focused right ventricular view. This is an apical view in which the left ventricle is sacrificed partly, and you see the whole of the right ventricle is seen, the whole of the lateral wall is seen, and you can see a good motion of the annulus toward the apex, which form the basis of some of the RV functions. So this is one view which everybody should practice and try to evaluate. Then the RV dimensions, like any other disease, again dimensions are important also. Now it can be sometimes a rough estimate can be taken visually on the basis that the ratio of the right ventricle and LV transverse diameter at basal segment in diastole should be less than 1 or so. And when it is rough, when it is roughly equal to LV, it is moderately enlarged, and when it is more than LV, it is severely enlarged. So one can get a visual impression. For example, here you see a parasternal long axis view. At one glance, you can see that the right ventricle is significantly enlarged as compared to the left ventricle, and the RVH is also present. So that is the reason one can get a visual. But sometimes when the left ventricle is also enlarged, then it may give a sort of a problem. Then one should practice doing a RV focus view and can see the maximum diameter at the basal 1/3 or at the papillary muscle level. And keeping these figures in mind, at the mid RV, the abnormal figures are more than 3.5 centimeters and basal RV more than 4.2. So again, it is worthwhile practicing for the beginners also, so that they can always get used to for two things: an RV focus view and how to measure. After a number of trial and error, you will be perfect in various measurements. So now then, coming to the basic parameters, remember, we never base our diagnosis on a single parameter, but there have to be multiple, at least 2 to 3 parameters must be utilized before we reach a diagnosis in this. So that some of the longitudinal systolic functions are TAPSE, a tissue Doppler, S velocity, global longitudinal strain, and some of the fractional area changes and other things. And these are, we'll discuss the advanced ones subsequently. But I can tell you what is theoretical, what is practical. In many situations, we take an eyeballing. We see for the RV size, we see for the RV contractility, we see how the bases are moving, how the annulus are moving. So it can be reasonable for a daily working, and it can be a starting point that yes, there is nothing wrong in the RV functions, but it is experience dependent. So this is normally, sometimes eyeballing is very important, as you will see subsequently or so. And now, for example, here you see this is an advanced case of a right ventricular cardiomyopathy. Now, it is evident that there is a very severely depressed RV function, and even visually, we need not calculate various RV functions because it tells you that it is a very, very poor RV functions. So coming to the longitudinal systolic function, the major principle of this function is that the right ventricle has got a good amount of longitudinal muscle fibers, and these longitudinal muscle fibers cause a contraction in the longitudinal direction from the base to the apex. So like a piston, the more the movement of the base, the better is the RV function, indicating that there is a good longitudinal function. So it starts with a tricuspid annular plane systolic excursion, where we put an M mode cursor on the lateral annulus. And then when you put an M mode here, you can see the measurement from the base to the peak movement. And for example, here it is about 21 millimeters. Normal is more than 17. So this indicates that the base is moving much better, and that means it is a good longitudinal function. For example, here you see a case of a right ventricular cardiomyopathy, previously known as an arrhythmogenic dysplasia, where you see a sort of a echogenic papillary, a moderator band, systolic outpouchings, atrophy, and here you see there is hardly any motion of the annulus, and here one can see that the TAPSE is about 12 millimeters, and a tissue Doppler imaging, which is also one of the tests for the longitudinal function, are also significantly decreased. So some of the key practical tips for TAPSE is that it is an indicator of a RV longitudinal function. It is a practical index of RV function. Some persons have tried to calculate a RV reduction fraction by 2 into TAPSE, and as you see here, that one of the study with the CMR RV, they found when the TAPSE was more than 22 centimeters, they predicted a RV reduction fraction of more than 40, and when it was less than 15 millimeters, it projected a less than 40%, so that there is a good relationship of TAPSE with the RVEF. Again, one can do a bedside prognostic factor by a ratio of TAPSE and a systolic pulmonary artery pressure. It can be done within few seconds, because when there is an RV dysfunction, the TAPSE becomes reduced, and usually whenever there is a pulmonary hypertension, so when this becomes less, this becomes increased, so the ratio goes on decreasing. And this has been shown by a study in which you see the normal ratio was about 0.64, and as the ratio came down, the survival rate significantly decreased. And when the value was less than 0.35, it indicated a very poor prognosis, so that it is very easy to calculate it, and then you can get the whole prognostic factor within the few minutes or so. Then the same applies for the tissue Doppler imaging, which is again a longitudinal function, and sometimes it is heart rate dependent, and when the value is less than 10 centimeters per second, it indicates an RV dysfunction, and sometimes because it is related to the heart, and if there is a tachycardia or a bradycardia, you can correct it by the formula as systolic velocity into 75 divided by heart rate gives you the heart rate corrected systolic velocity. This was we used to do many years back when we were doing a tissue Doppler by the right ventricular isovolumic contraction acceleration time, but it is now becoming a bit doubtful, but still it may be done in some centers, will not go into it also. Then coming to the global functions, one is the RV fractional area change. Again, RV focused view, and it is the percentage change in RV area between end diastole and end systole, and the normal value is more than 35. The formula is diastole minus systole divided by diastole into 100. But the point to note is that trabeculations and PM should be excluded into pulmonary muscle, should be excluded into RV cavity. So that we have seen that in most of the situations we are using a focus view, and hence this is a very important view to be taken. This was one of our cases where there was a marked RV dysfunction and the value was only about 22% or so. So the key practical tips about the fractional area change is that it is an indicator of an RV longitudinal radial function. It has got some prognostic value in pulmonary hypertension. The limitations are a technical difficulty like an imaging quality and uncertainty of the correct tracing, that whether you are tracing the endocardium or you are tracing the papillary muscles or the trabeculae. So these are the two limitations, but otherwise it can be a good indication of a longitudinal and radial function. Coming to some of the advanced, so these are some of the basic ones which we normally determine. Now some of the advanced parameters also, a myocardial strain, it is defined as a deformation of an object compared with its initial shape and is expressed as a percentage. For example, here you see, this is the length at the given point of time, and this is the original length. And because here there is a shortening and thickening of the length, so it gives a minus value. So this is how you calculate a strain imaging also. When there is lengthening, it is a positive value, but normally we are more interested in a negative value. And so it is a measure of the percentage of a systolic shortening of RV free wall from base to apex compared to diastole, and we measure either an RV free wall or an RV global longitudinal strain. RV free wall is more informative because septum is not included in it, and the average value according to the ASC guidelines are minus 25% or so. So remember that this is the normal value, and it can be done if need be also. For example, here you see the right ventricle, and this is the graph how we get out the various segments, and this is, and you see a very markedly reduced global longitudinal strain with a value of only minus 7% or so, as indicated. This was a patient of an advanced pulmonary hypertension. Again, when you see various tracings, this is the average peak strain, and where it is overall markedly decreased. So that the key points about the longitudinal strain are, it is a good index of a global and a regional systolic function. It has got a significant prognostic importance depending upon the value. It overcomes the teethering effect which is normally seen in the ventricles. It is angle independent. Some of the limitations can be that only apical four-chamber view is available, unlike the left ventricle. It is image dependent, especially when there is a lateral wall seen, and because it has got a thin right ventricular wall, which is almost 1/6 of the left ventricle, so the width of the RO region of interest is limited because the region of interest is very important. So that is some limitation. Otherwise, it is being done frequently. Lastly, coming to the three-dimensional analysis, 3D echo holds a good promise to RV volumetric analysis, and it correlates well with CMR. How much it is done on a daily clinical practice, I am still doubtful. Although the AC also recommends that it should be utilized to see for an RV ejection fraction or so. And some of the latest equipment, they, besides giving the RV and diastolic and systolic and the ejection fraction, they also give us the value of the TAPSE and the fractional area change. So though it is a time-consuming process, but on a daily basis, I doubt how much it is being done. And whenever you do it, again, include moderator band and trabeculation in the RV cavity, and do not trace around it also. So these are some of the examples of the RV volume, and the status of the key points that awareness is increasing. There are no geometric assumptions. It is poised to be a very good tool, well validated with MRI. Some of the limitations are that RV anatomy may not be a good friend. Image quality, especially the RVOT and the dropout will be there. In a severely dilated ventricle, whole RV cannot be imaged. And the last one is a very debatable point. Is it ready for a routine daily practice? At least we don't do it on a daily routine clinical practice. And sometimes you can use a contrast when it is not clear, when the endocardium is not clear. And here you can see it is more of a Dobertine echo with a contrast enhanced, indicating a right coronary artery involvement in the form of an akinesia. And sometimes the same problem, this was the case of a right ventricular infarction with an akinesia of the lateral wall of this and significant RA dilatation. And this, of course, when your imaging is not very well seen, you cannot do a three-dimensional in this. So coming to the end, three views are very important, which will give you the complete RV function involvement. A four-chamber view to measure the baser RV dimension, whether you measure it or visual or tracing the RA area. This you can be by four-chamber view. A focused RV view will give you TAPSE, a tissue Doppler velocity, fractional shortening, GLS, and a 3D. And subcostal view will give you RV wall thickness and the IVC studies. So always concentrate on these three views, which will give you a full RV function involvement. And the numbers, we are happy if TAPSE is more than 17, fractional area change is more than 35, TDI, systolic wave is more than 10, MPI is more than 0.43, RV walls, free wall strain is more than -25, 3D RVF is more than 45, and the RV mid is less than 35 and area less than 18. So these are some of the figures which should always be kept in your echo lab, and then you can see it. So what is the optimal RV modality? What is the reality? The general consensus is, as each technique has its own limitation, a combination of approaches is still suggested for overall evaluation. And so where do we stand in day-to-day practice? A good clinical assessment. 2D echo will remain the clinical workhorse of RV evaluation. The visual impression of RV size, contractility, thickness is a starting point, and it may start or it may end here itself. Use simple and reproducible methods for routine studies like TAPSE, tissue Doppler, fractional area change, and a myocardial performance index. More sophisticated methods like strain and RVEF are promising advancements, and efforts should be made to make it as simpler and to be used in daily basis. This is a last slide, a very interesting slide in which the Binder et al. Sent a question here to about 1,200 participants from 109 countries as to which test you always prefer for doing an RV function. And what we have discussed just now, majority said eyeballing. Next said TAPSE. Then the third important came is the tissue Doppler. And the fourth came as a fractional area change. So these are we do these on a routine basis, and surprisingly, three-dimensional ejection fraction and a global longitudinal strain got a very minimum number of votes to be done on a routine basis or so. So that these continue to be the important methods, but they should be promoted and this. Thank you very much. My talk is finished now.
Thank you, Dr. S.K. Parashar, sir. Yeah, Sabina Pang, go on.
Thank you, sir, for making difficult topics palatable as always. Now I introduce our third speaker of this session, Dr. Aasha Gopal. Currently, she is the Director of Advanced Echocardiography, St. Francis Hospital, the Heart Center, Roslyn, New York. So her topic says, variant of aortic stenosis, does it make any difference of prognosis? And your time limit is 20 minutes. We are running ahead of time. Please, can you concise in 20 minutes? Aasha, please share your screen, please.
I'm trying to share my screen. Can everyone see that?
Yes, but yeah.
Slideshow? Yeah.
Yeah.
Okay, great. Thank you very much. Assalamu alaikum, everybody. I am really, really privileged to be here at this time. Congratulations to all of you for making this happen and during very difficult circumstances. It's 10:30 in New York, but despite the late hour, I'm really excited to be here. Thank you to Dr. Hashim, Dr. Nilufar, and Dr. Rahman for extending the invitation. So my topic today is to discuss the variants of aortic stenosis and to see whether it really makes a difference in prognosis. We're in the era of TAVR, and so I think this is an important thing to discuss. As everyone knows, this is an old slide, Jane Braunwald's, taken from Braunwald, which basically shows the natural history of aortic stenosis. As we all know, it's a disease of the elderly. There's a very long latent period when the patient is completely asymptomatic. There's increasing obstruction, myocardial overload, and all of a sudden the patient falls off a cliff. They're the onset of symptoms, and this is a very, very steep decline when you may have angina, syncope, and heart failure. And these obviously carry very reduced survival. For angina, it's roughly 5 years, for syncope, 3 years, and for heart failure, only 2 years. And so when you're at this stage, you're contemplating about what to do with the patient, you're balancing these kind of statistics with the risk of sudden death, 0.5% per year, the risk of surgery, 1%, and the risk of a prosthetic valve. So when a patient is symptomatic, it's pretty easy to decide that this patient must be referred for either transcatheter aortic valve replacement or surgical aortic valve replacement. Now in this talk, the classification of aortic stenosis severity is very well understood. And we're not talking about these categories in this talk. We're not talking about sclerosis or mild or moderate aortic stenosis. We're talking about severe aortic stenosis, where we primarily rely on the peak velocity, the mean gradient, and the aortic valve area. And these categories are very clearly delineated here. in order to make our determination as to what to do. So the reason peak velocity is a respected parameter is because it is directly related to outcome in a very sort of easy fashion to understand. As the peak velocity increases, you see that over a 3-year span, the likelihood of becoming event-free is very less. It really goes down. And in fact, Catherine Otto's data suggests that only 25% of patients with severe aortic stenosis will survive or will be really event-free at this point in time. So speaking of Catherine Otto, this is a very seminal study that she did in 1997, and yet there are many, I think, lessons that we can take from this. Once again, this is velocity and outcome. You can see that the 4 meters per second, which is sometimes we regard as a holy grail, is because the 5-year survival, pretty much all of these patients will not be event-free if their velocity exceeds 4 meters per second. However, this data importantly shows that these patients that we often see in the echo lab between 3 and 4 meters per second also do not have a very benign prognosis. Approximately only 20% of them will go on to have event-free survival over this 5-year period. It's only the patients where the velocity is less than 3 meters per second that we can, 85% of them will not have events over this period of time. So you can do some watchful waiting in this scenario. So again, the velocity is actually a marker of disease chronicity, and that's why it's respected so much. You can also talk about the mean gradient, which is another indicator of disease chronicity. And here, of course, we know the well-regarded criteria of greater than 40 millimeters of mercury mean gradient as being a demarcator of patients who will get into trouble. But here you also have another category of individuals where the gradient is extremely high. That is, the gradient is over 60 millimeters of mercury. They fall into a special category and a very high gradient. And these patients actually have a poorer prognosis in this kind of scenario. And finally, the valve area, of course, is also reflects disease chronicity. And it's easy to see here that patients with a lower valve area will get into trouble much earlier than patients with either mild to moderate aortic stenosis. Of course, the rate of progression is highly variable, but the often touted figure is 0.1 centimeters squared per year. And so that's something that has to be borne in mind. Now it turns out that the valve area is less important when the velocity is high or very high. So in individuals where the velocity is 4 to 6 meters per second, it really doesn't matter what the valve area is, whether it's greater than 0.6 or less than 0.6, their outcome continues to be poor. So we all know that there are inconsistencies in echocardiographic criteria for grading the severity of aortic stenosis. So the reason for these inconsistencies, there is a rough correlation between the mean gradient and the calculated aortic valve area. However, it's rough and there are many inconsistencies. Again, I'm not talking about the inconsistencies that you see with cardiac catheterization, where there are phenomenon of pressure recovery and so forth. But here you simply have a situation where the flow that is directed across the aortic valve does make a difference in the calculation of the valve area. So the flow is something that one has to really bear in mind. So when you look at the hemodynamic classifications of AS, severe AS, these are all patients that have valve area less than 1. You can actually come to 6 gradient flow categories of aortic stenosis. Those with normal flow and either very high gradient or high gradient, then you can have a high gradient low flow situation. And then you have those with low gradient where the flow can either be low or the flow can be normal. And the definitions of very high, as I told you before, is greater than 60 millimeters of mercury. The high would mean that the mean gradient is greater than 40. And of course, something that we should be calculating in all our patients is a stroke volume index, because it is not exactly the same as flow, but it is correlated with flow. So the stroke volume index is something that we should be calculating in all our patients. So let's tackle the first couple of criteria, the first couple of categories where the gradient is either very high or high, but the flow is normal. So this category actually turns out to be the most prevalent category of anywhere between 40 and 70%. These patients tend to have more severe aortic stenosis. They have a longer exposure to this disease because their velocities are higher, the gradients are higher, etc. However, there is no, the longitudinal function is preserved in these individuals. So there really is no even subtle left ventricular dysfunction. They're able to generate these high gradients. The BNP, as you can imagine, is higher, and the cardiac event-free survival is reduced. Now, when they become symptomatic, our cath colleagues are, often very gradient dependent. They really want to know what the gradient is. So because their gradients are high or very high, they tend to be referred for AVRs, whether it's a TAVR or a surgical, because they're easily recognizable. When they're asymptomatic, then you need to do further risk class stratification, perhaps with stress echocardiography, etc. But again, these patients are usually caught pretty early on and referred for the appropriate management. Now let's look at the second type of category where the flow is actually low, but the gradient is high. And I'll show you an example of that. So this is a patient, parasternal long axis view, where I think you can appreciate that there's good ventricular function overall. There's severe calcification of the aortic leaflets. There's also severe mitral annular calcification, which goes hand in hand. The short axis view at the papillary muscle level and apex shows, again, good ventricular function. The ejection fraction here is normal. The short axis view here shows a highly calcified aortic valve, which barely opens. So, and here you would imagine that the flow is normal, and yet you don't have an aortic valve that opens. Here you've got the patient with severe tricuspid regurgitation. Dr. Parashar was telling us about right ventricular dysfunction. Well, this is a patient where the BNP has been very high, and it's affected the right side, so much so that you have severe TR. And you also have at least moderate to severe pulmonary hypertension. This is the TR velocity. So you've got very high, you've got pulmonary hypertension. In looking at the apical view, you can see that both atria are dilated, again, showing you that this patient is operating at high left ventricular end diastolic pressure. The ejection fraction, however, tends to be normal. So when you actually do a CW Doppler of this valve, you'll see that the Vmax is extremely high, over 6 meters per second, again, falling into that very severe category. And the mean gradient is 19 millimeters of mercury. I think this is like one of the highest gradients I've seen in my career. And the maximum gradient is over 150. Now, you would imagine that this patient, since the ejection fraction was normal and the contractility, at least visually, seemed very good, you would expect the stroke volume index to be normal. However, in this individual, the stroke volume index you see is 32, which is actually kind of low. It turns out that the LVOT diameter in this patient was actually fairly normal. So you cannot really blame it on just not calculating the stroke volume index correctly. So this type of high gradient, low flow aortic stenosis, the prevalence of this is much lower. And these patients actually do have subtle ventricular impairment. They have depressed longitudinal function. If you did strain imaging, you would probably be able to detect that. And they can have a preserved ejection fraction. Their BNP does tend to be very high. They have significant left ventricular remodeling. They do become symptomatic soon, particularly since their gradients are high and there is ventricular impairment. They have either the same or actually worse prognosis as those patients with high gradient normal flow aortic stenosis. And they certainly have a better survival with AVR. Again, these patients are picked up early. They usually don't slip through the cracks because their gradient is high. So they recognize fairly early on. So now let's concentrate on the low gradient scenarios where the gradient can either be low due to a depression in ejection fraction, which is the classical variety, or the ejection fraction can be normal, which is the paradoxical variety. And a third category where you have the low gradient, but the flow is normal. So in this kind of scenario, you have an aortic valve area less than 1, a mean gradient of less than 40. So this qualifies as low gradient AS. If you then consider the left ventricular ejection fraction, if it is depressed, you have the classical variety of low flow, low gradient AS. Here the ventricle is dilated. This is a ventricular problem to a large extent. And of course, the low gradient is because you have low flow. Now, in the situations where the ejection fraction is normal, that is greater than 50%, the next thing you can do is calculate a stroke volume index to see whether the stroke volume index is low, in which case this is paradoxical low flow, low gradient aortic stenosis. You notice here that these patients tend to have small hearts. They tend to have very hypertrophied hearts. And the reason for the low flow, low gradient may be that they have some form of ventricular impairment. That should be contrasted against those individuals where the stroke volume index is normal and you have a normal flow but still low gradient. So we'll discuss this in the end. Again, let me show you an example. So this is a patient where the parasternal long axis view, you clearly see that there is impaired ventricular function. This anteroseptum is hypocontractile. Again, on the short axis view, you see that this whole area of the septum is hypocontractile. And if you look at their Vmax, you see that it's in that intermediate category between 3 and 4 meter per second, Catherine Otto's category. The mean gradient does not quite meet criteria for high gradient, so this is low gradient. And if you calculate the stroke volume index, you see that the stroke volume index is very low. So this is a patient clearly with low stroke volume index, despite the fact that we use a fairly normal left ventricular outflow tract diameter. You know that this category is, this is something obviously influences your calculation of the stroke volume index. And I just want to make a point here that the flow is actually not the same as stroke volume index. The flow takes into consideration the ejection time. So this is actually just a measurement of how much blood is flowing through the aortic valve per unit time. And in this individual, this is actually a low flow. So the normal flow is approximately 250 milliliters per second, and here the flow is reduced. So it's important, once again, to calculate this in all of your patients with low gradients. Now, if you give this patient dobutamine, as we did here, 5 micrograms per kilogram per minute, you see that the LVOT VTI did increase from 16 to 19. So this is a surrogate of actually stroke volume index. So this is actually what I follow when I give my patients dobutamine. I just keep going till the LVOT reaches a maximum. And you can see that this increased 18%. And if you give more dobutamine, now at 10 mics, you see that there's no further increase in the VTI. So in fact, you can get a less of an increase in stroke volume. So this is what I use to do it. And there's no magic. You can even go up to 15 mics or 20 mics of dobutamine as long as you achieve that maximum. And this is important because what you're trying to calculate is this patient's response to the dobutamine, and a recalculation of the aortic valve will say that this patient falls into the true aortic stenosis category. But is that really the case? This patient's recalculated aortic valve area came out to be 0.8. However, the stroke volume, the flow across the aortic valve only increased from 193 to 203. And the stroke volume index really didn't increase very much. So what you can do in these situations is actually calculate an aortic valve area projected at normal flow rates. You have everything that you need when you're doing a dobutamine stress echo. You have the aortic valve area at rest. You have the change in aortic valve. You have the change in flow, and you have the resting flow. And if you calculate that, you see that the flow just increased only 5%, and yet the calculated aortic valve area comes out to less than 0.8. However, this situation, this is really valid only if the flow increases by at least 15%. So in other words, you need a certain amount of flow, a certain amount of oomph, if you will, to open up these aortic valve leaflets. And even if you do a TEE in these individuals to look at the planimetered valve area, you can be off because, again, you need that certain amount of flow in order to keep things open. So this, again, just highlights the use of dobutamine stress echocardiography to calculate the flow reserve. And if the flow reserve is normal and you get a high gradient and the valve area calculates to less than 1, then you have true severe AS. If the gradient, on the other hand, remains low and the valve area is actually more than 1, then you have really just a ventricular dysfunction scenario with pseudo-severe AS, and heart failure treatment would be the most appropriate response. Now, what do you do in this individual that I showed you before, where the stroke volume really did not increase sufficiently and it was less than 20%? So here you don't know whether this patient really has severe AS or not. So in this scenario, there is a role for determining the calcium score. And there are different values for calcium score, whether you're a woman or a man. And this actually correlates with the physical amount of obstruction of the leaflets themselves due to a piling up of calcium. And so that is something that we do use in those patients with diminished flow reserve, and you want to make the case that they should be intervened on. The one other parameter that I want to impress on is calculation of global left ventricular afterload or valvular arterial impedance. Now, everybody knows that aortic stenosis is a disease of the elderly. So in addition to having obstruction at the level of the valve, you also have obstruction after the valve. In other words, the afterload may be high due to vascular stiffness because the patients are elderly, or you can have systolic hypertension that is causing this global LV afterload. So this is a double whammy for the ventricle to sustain. It's facing a double scenario. So you can actually calculate this impedance by looking at the systolic arterial pressure, the mean pressure gradient, and the stroke volume index. And we routinely do this. And you know that a value of the global afterload, if it's more than 5, that's associated with a poor. However, what I should impress upon is that this global afterload itself is a flow-dependent parameter. And you see that in low flow states, a very small change in stroke volume will actually cause a big change in this global afterload. So it is less reliable in low flow states. So that's something that has to be borne in mind when you're doing these calculations. So in terms of the low gradient, low flow aortic stenosis, whether it's the classical variety or the paradoxical variety, the prevalence, you can have patients who are asymptomatic, but most of these patients are in fact symptomatic. Here you have more pronounced LV.
Dr. Aasha, we have 1 minute time left.
Sure, I'm almost.
Yes, yeah.
You have a smaller LV cavity, you have increased global afterload, and in these patients, the prognosis is very grim because these patients actually are misdiagnosed. The severity of AS is often underestimated. And if that's the case, then they're not referred, or AVR is usually delayed. So again, the class 2A criteria for these patients is actually to refer them for surgery or a TAVR. So the last category is low gradient normal flow aortic stenosis. And I just want to finish this by saying that this is actually just simply put, when the flow is normal, this is a scenario where there's just less severe aortic stenosis. This is a shorter exposure to this disease. So this patient actually has a better prognosis compared to the other categories. And therefore it's important to see whether the symptoms are actually due to aortic stenosis itself or they're due to other comorbidities. So in conclusion, again, the low flow scenarios are the ones that are the most difficult to sort out. And the butylamine stress echocardiography, calcium scoring, and calculating the global LV afterload is again very helpful in sorting these patients out. Thank you very much for your attention.
Professor Swaminathan.
Thank you, Aasha, for joining in our conference and delivering an excellent presentation. And now the floor is open for discussion. I think, Nilufar, there is a question. Can you please, for Dr. Parashar, can you please?
Dr. Ahmed Mamunul Haq asked Dr. Parashar sir, can we classify RV dysfunction into mild, moderate, severe based on the echo parameters? Dr. Parashar sir.
Yeah, because depending upon what parameters you are taking, say they have been labeled mainly on the what are the values you get. So we are mainly concerned with severe and mild. Moderate comes in between also. So if you take any value what we have given, the lesser the value, the more severe is the disease. Whether it is a TAPSE, whether it is systolic velocity, or whether it is the other things also. So the lesser the velocity, the lesser the value. For example, in a ejection fraction, if it is less than 20, it means it is almost a severe aortic stenosis. So they depend upon, you can say, but mostly we are only saying that the RV dysfunction is present. When you are sure, then you can say that yes, it is moderately deranged or severely deranged. For example, the one picture I showed, that was a severe associated, severe thing by visual impression also. So whether you do, so yes, you can say that whether it is a severe RV dysfunction also, depending upon how less are the values.
Okay, thank you, sir. We have no more question and in the chat box, and we are running out of our time. So, Appa, Sabina Appa, any question from panelists? Panelists can ask question. One question. We'll take one question.
Any comments from the chairpersons, please?
And thank you. I am Professor Jamal. Thank you for all the speakers for their excellent speech and showing the different avenue in the diagnostic field by the echocardiography, particularly the speaker who presented the variants of aortic stenosis. This is very important, but most of the people do not understand it. But you have clearly differentiated different subsets, which has become very effective for our younger generation, those who are doing the echocardiography. And another field, echo in ICU in COVID era. This is very important in this setting all over the world. And you have shown the different types how we shall do echocardiography. But I have one recent question, that is one question of recent evidence that World Health Organization, the 1 or 2 day back, they have told no mask, no social distancing is essential for avoiding the COVID-19 era. If it is so, then is there any difference of doing echocardiography in ICU suffering from COVID era? This is my question to you.
Sir, Dr. Madhav, big apology. He could not join now. He left the meeting. So Parashar sir will answer.
The thing is that what somebody says is different what we do. Now suppose I have to do a transesophageal echo. Will I not wear a mask or will I not do a social distancing? Say everywhere now whatever the WHO says is different, but it has been proved that mask, social distancing and hand washing still continues to be the mainstay for the prevention. There is no curative treatment, no preventive treatment also. And every society has made some guidelines for COVID patients also. So that I still feel that a social distancing and the masking is still a very important preventive measure also.
Even practically, we have also seen that doing echocardiography of a single patient and COVID-19 positive by the physician, it has been shown. Besides this, even in temporary pacemaker performing, one patient, a temporary pacemaker done by one consultant and with his associates, all the 5 doctors became positive. So it must be, but WHO is telling like this, and that is why my question was.
Okay, so we are end of our session. Sabinappa?
Can I just make a little comment? I'm Dr. Shahbaz from Pakistan.
Yes, sir, we are coming to you. You will be the concluding remarks by you. Professor Sabinappa?
Yes, yes, Professor Shahbaz, can you give some comments for us? Yes.
Thank you very much for giving me this invitation, and I'm grateful to Colonel Parashar for making me a part of this Bangladesh ECHO conference, which is really very good. And my journey for ECHO started with Professor Nazrul Islam, who's a friend of mine. We started in 1979, 1980. And as Parashar very correctly pointed out at the end, that knowledge is the journey and not the destination, actually. I was a junior medical officer when Brigadier Abdul Malik was running a cardiac clinic in Rawalpindi. So actually, I have seen the development of echo from M mode to 2-dimensional echo to color Doppler, and then finally to the tissue Doppler imaging, and now to the strain imaging. And what I feel is that the speakers did an excellent job. Dr. Madhav from the United States, what he elaborated in his talk of COVID-19 is what we all should practice. And the second talk by Parashar was another talk par excellence. I've always enjoyed his talks, and I think I've learned so much from him that I may one day be saying that he's one of my mentors also, though I have met him only a few times. And Dr. Aasha also did full justice to her talk on aortic stenosis. And we are seeing so many of these cases. And what I feel now is that there is another aspect in aortic stenosis, and that is the multimodality imaging with multidimensional, with the CT angio, which will give you a very correct assessment of the aortic valve area, which can be done very clearly and is being used in Tower also. So I think that Bangladesh ECHO conference has been an excellent one, and I'm really very happy to be a part of it. And thank you very much, Professor Nazrul Islam, and thank you very much, Colonel Parashar, for making me a part of it. And I congratulate all the speakers for their excellent lectures, perhaps one of the best that I have heard. Thank you very much.
Now we are end of our session, and Dr. Colonel Parashar to make concluding remarks for this session.
I was a speaker. How can I give a comment? I think it was a very practically oriented session also, and I would have liked more questions and say what we want to discuss only the practical aspects. We want theoretical aspects also. For example, whatever has been told by us, including Aasha, whatever we have been told, they should practice regularly. They should practice. If today they want to calculate the valvular artery impedance, the day they want, they'll not be able to do it. Getting a focused RVU, they should do it. So they should start with the basic. Go on practicing. Only practice makes you perfect, and then go to the higher studies also. But I would suggest it was a very well-designed session with a good topics also. So I think we should not waste more time, and it was nice to hear some good comments from Professor Qureshi from Pakistan. But overall, because we are short of time, so let us continue to the next session, please.
Thank you, sir.
Next session moderator.